very much for that kind introduction. So, it's very difficult to follow such an inspiring talk with such fantastic results. I work in secondary care, and where again we are trying to address smoking cessation in a different and slightly unconventional way. And we're doing it specifically by targeting death certification, including smoking as a cause or contributing factor to death. And in order for you to understand what an impact that has, I'm going to explain the role of the medical examiner and how death certification raises the awareness amongst families to look at their lifestyle choices, including smoking, and also, very importantly, how we can educate our colleagues, medical, nursing, clinical, and I will demonstrate it with what we've done in Southampton. I think we've seen a massive culture change over the last few decades, from accepting death, that's just something that happens, to looking at actually what's natural, what's avoidable, and how can we do better in preventing death. And the first systematic inquiry into death was the NCPOD report, which most people will be familiar with. And I reread the details in preparation for this talk, and they made eight recommendations. And we've taken up 2 so far in the last 35 years. And addressing lifestyle choices to reduce anaesthetic risk, and that included smoking, was one of the recommendations that was made in 1989. At the same time, the first kind of hint of league tables amongst hospitals was being produced by surgeons and anaesthetists reviewing perioperative deaths and saying, actually, this is avoidable, we could have done better. So, as a consequence, in most secondary care institutions, mortality and morbidity meetings were set up to ensure safe practice, to reassure patients that we're looking at how we work. But they're not systematic, they're quite surgically driven, and my personal experience is probably that of many of us in the room. The biggest personalities in the room had most to say. There wasn't really much systematic learning, and on the whole, they didn't really achieve the change that we needed to prevent avoidable harm. Although, obviously, there are some excellent meetings, and I've been to some recent respiratory M&M meetings locally that I've learned a lot from. Then came the medical scandals, of which we're all very familiar with. And I think we really have to take a step back and think, what's the effect on the general public been? They see us as healthcare professionals, especially doctors, completely differently how they saw us in the early 90s. We've lost their trust, and they think we're all the same. Whereas for us, we think, well, you know, there's not going to be another Shipman, there's not going to be another Stafford. Things are different because we work well locally. So I joined Southampton from a different trust in 2012, and one of the first things I was asked to do was to chair the thrombosis committee. And we had our very own little scandal all over the local news, which essentially was a patient who died of cancer, who would have died anyway, but probably died much sooner than he needed to have done, because we failed to diagnose a blood clot, and that led to his early death. Not only did we fail to diagnose it in a timely fashion, when we did diagnose it, we didn't give the appropriate treatment. And that was our own moment of truth at Southampton. So we looked at 3 decades of evidence of avoidable harm. We looked at what recommendations have been made nationally. We looked at our own ranking with the hospital standardised mortality ratio. And we found that despite all the good clinical initiatives and all the things we're doing for our living patients, we were poorly coordinating death certification. It was a poor experience for the bereaved, it was a poor experience for the junior doctors, it was a poor experience for the bereavement officers who had to essentially fib, to say, well, we don't know when the doctors are coming, or the doctors are very busy, oh, it's in hand. And it was very distressing for the nurses as well, not being able to give information of how the process would work and when the bereaved families could obtain the necessary paperwork. So that late diagnosis of a pulmonary embolus with the failure to instigate treatment, relook at our internal processes, made us decide that we needed to do something differently regarding the death certification process. I know this all sounds very negative, so I just felt I needed to say, this is my crime watch moment, the NHS is safe. I think on the whole, we're doing fantastic things such as coming to conferences on a Saturday. So we looked at the medical examiner role in detail and learned that it had been recommended by 4 major public inquiries, and that indeed, with some delay, that there was now a legal framework to introduce this. In fact, a national medical examiner, Professor Peter Furness, was appointed in 2008. Unfortunately, the legal framework wasn't there for him to fulfill his role meaningfully, and the funding wasn't provided to set up medical examiner service. A great loss in my personal opinion. And as part of the introduction of the medical examiner and reforms to death certification, there's a clear statement in the guidance from the government that death certificates need to include contributory factors and causes, not just diseases of death. And I think that is a really important point, because smoking is not a disease, it's a factor, or it's a behaviour. So the Department of Health recommends that the medical examiner role serves several functions, including increasing the safeguard and reassurance for the public, improving the quality of death certification, and avoiding unnecessary distress for the bereaved. And this brief really fitted the problem we wished to fix. And when we looked at in detail at what the recommendations would be, how we could implement them, it was recommended that an experienced doctor would review the case notes at a distance and kind of pass judgment in that quite autocratic way on whether the cause of death had been documented accurately. And we felt that that was not the approach we wanted to take, that we wanted to use it as an opportunity to improve quality, provide education for our junior medical staff, and to ensure that death certification is carried out accurately. So we set up our internal medical examiners group to start in 2014. We decided that we would review every single adult death in our hospital. We have 50,000 emergency admissions a year. We have roughly between 2,000 and 2,200 deaths a year. Very few of those are fortunately paediatric. Because we're per tertiary referral centre for paediatrics, we do have paediatrics death, and we have started working on that last year. We have a face-to-face meeting with the treating doctor, and that could be a consultant or any other grade of doctor. We are a panel of 8 senior clinicians, pathologists, surgeons, cardiologists, intensivists, physicians, and we run a meeting together with the bereavement officer on a twice daily basis to fit with the junior doctor shift pattern, so those doctors who finish night shifts can come to the meeting before they go home. We make it a one-stop visit where the doctors can fill in all the relevant paperwork, where we discuss whether hospital or coroner's post-mortem is appropriate, and where the junior doctors can raise issues that are important for the bereavement team to know before they give the death certificate to the bereaved. So the benefits we saw as the medical examiner group was that we really were able to fulfill the duty of candour. Following that VTE incident, we had implemented that every single patient who dies in a hospital of a blood clot gets a letter proactively saying, this is a hospital-acquired condition, we are going to investigate it. This is the panel meeting, you're most welcome to join us. Not a single family has asked to join, we've had lots of compliments that they felt very reassured about our openness and of our willingness to discuss how we can improve practice with our patients. With the same method, we refer all falls, pressure ulcers and health-acquired infections to appropriate internal panels. It's a fantastic opportunity, we felt, for our junior doctors, especially and also consultants, to talk about those unanswered questions, those lingering things. Might I have done something differently? Could that have led to a different outcome? And that is really important for the bereavement team. At the same time, the bereavement team have been hugely skilled up in what diseases kill and how the pattern recognition work, and that's really helped with introducing lifestyle factors. The benefits for staff has been supportive, it's safe, it's an opportunity for pattern recognition. So we all do 2 or 3 sessions a week, so you do it often enough to develop really good practice. And I had a week where the patient on the acute stroke unit died of a rare complication, a side effect of a heparin infusion. And the next day I got a patient on an elderly care ward who died from the same condition, which was absolutely not expected as part of their presentation. On the 3rd day I got someone in cardiothoracic ITU who developed the same complication, and suddenly the penny dropped that it might be the heparin batch that is at fault. Within half an hour of that meeting, I was able to get in touch with our chief pharmacist. That batch of heparin was taken off the shelf, and the patient, hopefully no further patients came to any harm. But it's also a really good opportunity to share good practice and learning, and we're able to do that increasingly. Also increasingly, consultant colleagues come for advice and saying, this is what happened, what do you think? Do we need to consider this for further action? Do we need to do things differently? And it's really been a joy to build up this multi-professional team over an 18-month period. I think the benefits for public health are obvious. The improved information accuracy. We've got improved working relations with our local coroner's office, and we have an improved use of public resources because we provide accurate information, and because we include all contributing factors to causes of death, it's an opportunity to influence behaviours for the families of our deceased patients and their friends. So, how has our death certification improved? It's only worth looking at the very beginning of our project because it's so established now that we wouldn't see such massive changes. But if you would we're thinking of doing something in your area of work, in primary care or secondary care, I think in the beginning you see a massive change in the quality of death certification. So on our documentation, we always write down what the team suggests the cause of death is, and on the other side, we document how we've changed it. And as you can see, in the first month of doing internal medical examiner meetings, only a quarter of death certificates remained unchanged, and that went up to half after 3 months. Now we probably change 5 or 10%. We made significant changes in almost half the death certificate in our first month of implementing this. And the significant changes included information accuracy, because junior doctors have tendency of just putting the whole past medical history on because it feels so good, how hard we worked at putting all that on. And starting to put on directly contributing factors such as smoking contributes to lung cancer. We also were able to investigate about 10% of our deaths through our internal mechanisms that would have otherwise not been picked up. So in a year we roughly refer 600 cases now for further investigations, either as an urgent scoping meeting at the top or an incident report at the bottom of patients where we feel care could have been improved. And we feel that's a very important part of our work as internal medical examiners. We've massively increased our post-mortem rate. And we asked our service users what they felt, and they said it was better than the old system, that the questioning from the medical examiners was fair, that it can be a useful learning experience and can change clinical practice, and that it is facilitating talking to the coroner's officer, and it has improved their understanding of death certification. So we got to this point after a year, we felt quite good. We'd achieved quite a lot, we'd established a system, and then we looked at the work that was left to do, and we felt that we didn't really include palliative care sufficiently, and that we were not consistent in our lifestyle documentation, the death certificate. So as a group of 8, we agreed that that was our most important step. And I realised that I've left this to the end of the talk of how the smoking fits in, but I felt it was really important to understand the journey, and that it took us a year to understand how important it was to include smoking, obesity and alcohol dependence in death certification. So as a group of 8, we agreed that that was an important thing to do, and we just started doing it quietly. And it was a rocky road, it didn't go too well. And unfortunately, I was introduced to our colleagues from the London Clinical Senate, Noel Baxter and Louise Restrick, and I took part in a study day on how we can improve death certification and smoking. And I came back to Southampton full of enthusiasm. And my colleagues said, of course, if they're doing it, we're as good as London, we're doing it too. But we're going to go one better. We're going to include obesity, and we're going to include alcohol dependence. And that's what we've done. So, interestingly, we've marketed this as it's the right thing to do for our patients and our families. It meets the duty of candour. It provides an accurate documentation of the cause of death. And it provides an opportunity to create a better future for the families and friends of our bereaved Interestingly, there was reluctance by all doctors of all grades to include smoking, interestingly more than obesity or alcohol onto death certification. And I hate to add it, but my respiratory consultant colleagues at Southampton were really quite difficult to persuade that smoking was an important thing if a patient died of a smoking-related disease to document. And when we explored that conversation a little bit, it really comes back to avoiding the difficult conversation. And the conversation that was never had with the patient would now have to have with the family, and that almost they felt it was a lack of respect to speak badly of the dead and to criticise a lifestyle of somebody who can no longer answer for themselves. However, we presented them with external evidence and a lot of the work that's been done in London, and we encourage each other informally. So in order to really get this established, it took us about 3 months with intense doctor education, bereavement team education, and a slow and gentle introduction. And we're now in a position where there's widespread acceptance of the facts that if you die of a smoking-related disease, and that's obviously far bigger than respiratory disease, that goes onto the death certificate either as a cause or as a contributing factor. We've really disseminated the knowledge amongst doctors and amongst the bereavement team, because, as we heard in the previous talk, one doesn't need to be a healthcare professional to really deliver a positive message on changing lifestyle options. We also realised that alcohol was another area that we needed to work on with our staff, and together with the AHSN in Wessex, we've developed a Know Your Own Numbers tool where we started educating staff around alcohol units consumed, so we can go down the same lines of accuracy. So our next step is to look at our internal medical examiner service 7 days a week, and to see how it influences our hospital standardised mortality rate. Initially, we dropped from 108 to 95. At the moment, we're creeping up again, but I'm hopeful that we'll get that under control. We work with all our teams to really embed this into our service. So my summary is that a framework exists national pilots exists. It has a real positive impact on patients' outcome and on clinical care, on doctor education, and most importantly on the bereaved. We get fewer complaints from bereaved families because they feel they understand things, and it's an opportunity to develop quality projects throughout the healthcare system. And before I finish, I'd like to leave you with one story. I'd had a major computer failure and I had to rewrite this presentation on the train up yesterday evening. And opposite me sat two elderly ladies from Eastbourne. And they said, "Oh, what are you doing?" And I said, "Well, unfortunately, I still got a little bit of work to do." "Oh, what's your job?" "I'm a doctor." "Oh, why are you working on a Saturday?" And I said, "Well, I'm going to a conference to speak about a topic I'm really quite passionate about, and there will be hundreds of other people as well who are passionate on the same topic." "What's the topic?" "Oh, it's about stopping smoking." So, we are gagging for a fag over here, and she's talking about stopping smoking. And they said, "Anyway, tell us what you talk about." I said, "Oh no, it's a Friday night, it's far too serious, let's not talk about that now." They said, "No, honestly, we want to know." So they got the 5-minute potted version of, we need to talk about smoking cessation. I said, "Well, my Uncle Bertie, he got to 92 and he had a really good life and he was a smoker." And I said, "Yeah, we all have Uncle Berties." I said, "But could I ask you, is he alive now?" No, he's dead." And I said, "Well, what did he die of?" "Oh, there's nothing much wrong with him, love. Once he's had his right leg off and he's had that vascular thing, that stroke thing, he was fine. He lived another 30 years and he smoked 40 a day." So, and I said, "Well, he wasn't fine then, really, was he? He had some diseases that are smoking related." And they said, "Yeah, but that's what our children say. We're not allowed to stop. We're not allowed to smoke in front of the grandchildren." And they said, "But for us, love, it's too late. Smoking will be on our death certificate, but I guarantee you it won't be on our children's and grandchildren's." And she said that so wonderfully. So I asked her, was I allowed to share it today? And so here's the story from the train last night, and I thought it was just fantastic. Thank you.